Hello, everyone, and thank you for joining today's program. My name is Annette Iyer, and I am the National Assistant Vice President for Patient Engagement for the American Lung Association. We're very excited during Lung Cancer Awareness Month to kick off our Lung Cancer Patient Virtual Meetup on the Go series. Today's program is called Update on Immunotherapy for Lung Cancer. I want to acknowledge and say thank you to today's program sponsor, Cleveland Clinic, Martin Health in Florida, for their continued support on important lung cancer education and awareness programs like today. We created the Virtual Meetup on the Go series in response from feedback from many of you and our lung cancer patient community. We asked folks what you want to learn more about and how you want to hear that information. And overwhelmingly, the response was that individuals wanted the chance to attend programs, but more importantly, they wanted the chance to view videos on demand. So that's what we're going to do. Today's program will be recorded and it will be available throughout the month of November and December. A few housekeeping items. Today's program is being recorded and all of the participants are in mute-only mode. We will use the chat feature to ask any questions. If we run out of time during the program, we will follow up with Dr. Sater to answer your questions and send you a response. At this time, it is my privilege to introduce today's speaker, Dr. Houssen Sater, who is a board-certified medical hematologist, oncologist, and physician scientist with the Robert and Carol Weissman Cancer Center at Cleveland Clinic Martin Health. Dr. Sater leads cancer research at Martin Health and works alongside Cleveland Clinic Florida researchers to advance cancer immunotherapy and provide more personalized treatment options for patients with cancer. Dr. Sater earned his medical degree at Lebanese University in Beirut. He completed residency programs at the National Institute of Pathology in Beirut and at the Northwell University Hospital in New York. He completed fellowship training programs at the Jules Bordet Institute in Belgium and at Georgia Cancer Center in Augusta. Dr. Sater is a board certified in internal medicine, medical hematology, and medical oncology. Prior to joining Martin Health, he worked at the National Cancer Institute, where he served on faculty as an assistant research physician in medical oncology. He led the Tumor Immune Microenvironment Laboratory and was an early phase clinical trialist with a special focus on immune therapy of cancer. At this time, it is our honor and our privilege that I'd like to turn the program over to Dr. Sater.
Well, thank you, Annette, and thank you for the American Lung Association for hosting me today, and thank you for our audience for spending the time with us this morning. So I'm going to say that I'm going to be focusing on updates on immunotherapy with special focus on early stage lung cancer. That being said, I'll go over a few items that will be helpful for you, hopefully, to walk through your journey when you have a lung cancer diagnosis with your doctor. First of all, based on the recommendations from Cleveland Clinic and the CDC and other authorities, we here at Cleveland Clinic, we value your safety and those around you very highly. So we always ask that you take precautions, including practicing social and physical distancing and wearing a mask while in our facilities, but also washing and sanitizing your hands as much as you can whenever you're touching other people. I have no disclosures for this talk. First of all, I want to just walk you through what immunotherapy is. Scientists for decades have argued whether immunotherapy is something or not. And in very simple words, the question was always whether the immune system is actually helpful to get rid of the cancer or not. And then eventually everyone agreed that the immune therapy is definitely in fight with cancer. Now, if the cancer takes over, that leads to escape of the immune system, and the cancer will show up on scans, and also, God forbid, if it was aggressive, will take the patient's life away. Now, there are instances where the immune system can actually take over and the cancer will not show up, or if it showed up, it will go away. Now, there are instances in between where the both of them are actually in equilibrium. And this is what we're trying to do with the immune therapy, bringing that escape down or back to equilibrium or even to elimination to get rid of cancer. This could be very technical, but the very essence of having an immune system work against our cancer is to help our immune cells, particularly something called T cells, part of our white blood cells, to recognize the tumor cells as a foreigner. So to do that, typically the cancer cells will have something presented on their surface. What you see here in green is basically called an antigen, and that's basically proteins expressed within the tumor and show up on the surface by a protein that expresses on the surface of any cell those proteins called MHC, or major histocompatibility complex. Now, why is this important? Is because you want that cell to recognize the tumor so that it be able to get rid of it. Once it recognizes it, what happens is it needs another signal that comes to play to regulate the immune cell to be able to fire its weapons, which are in this case, like you see, the granzyme B and other, in order to actually lead to the cell death of the tumor. And what you see here, basically, immune cell recognizing the tumor, and it leads basically to its disappearance or death because of that. So it is true that immune cells can recognize the tumor and can kill it. Now, what happens is, unfortunately, the tumor cells can raise a flag. That flag is like a marker that would tell the immune cell that we are actually similar to you or to the rest of the body, and it would say, go away, we don't need you to come and kill us, we are similar to you, we're not a foreigner. That signal, that is basically the other signal that now you hear about, is called PD-L1, and that's typically expressed on the tumor cells themselves, and they are the white flags that actually break away or take away those immune cells. You can see them going away from the tumor. Now, what we do in immunotherapy, and this is where the focus of my talk is to break that interaction between the PD-1 and PD-L1, for example, or other checkpoints. Now, these flags or proteins, they're typically referred to as checkpoints, whether it's PD-L1 or other markers that you might have heard of, like CTLA4, LAG3, and others. Now, unfortunately, it's not only about this that causes the immune cells to deter away from killing the cancer. There are other factors that lead to immune suppression, which means making the immune cells weak. And those are different markers that are expressed by the tumor. And this is examples of that, which basically like TGF-beta, interleukin 10, and IDO. And there are other immune cells, unfortunately, that play a negative role in hindering the response, which are basically here something that you might hear of if you're too advanced into this topic, which is basically called T regulatory cells, or Tregs. Now, that being said, the PD-L1 that I just mentioned to you is actually a protein that we can measure by doing a staining in the lab. So typically that we would take your specimen, like a biopsy of your tumor, and we will actually take it to a laboratory of pathology, and we can stain for it. And you can see basically an example of a positive PD-L1 here. It's all around the surface of the tumor cells, and it's showing in brown compared basically to a negative tumor, which expresses no PD-L1 whatsoever. Why is it important? Why am I telling you about this? One, because your doctor might be actually sending your tumor out for this, and plus, there are different scoring systems. I'm not going into the details of this, but suffice to say that there are different scoring systems that would determine whether you would respond to certain therapy like immune therapy or not, or would determine what treatment options you have for your lung cancer. So you will hear about, for example, CPS score, TPS, and IC score, and all it means is basically, are we scoring the tumor and the immune cell, or the immune cell alone, or the tumor alone, or a combination of the two? Now, if we block that axis that I told you about, we get humongous responses. And this is just an example of somebody with Merkel cell lymphoma at the National Cancer Institute treated with avelumab with this trial. And you can see the significant response that the patient had in only a few months. Now, this is to show you that it's not only in Merkel cell, but also in other types of tumors, including basically non-small cell lung cancer. And what you see here is basically a drop in the sizes of the tumors. So the way to look at this is a spider plot, and the way to look at this is a drop in the sizes of tumor down to complete resolution of tumors to 100%. Now, not everybody responds, and there are a lot of patients that actually go up in their size, and this is where they have no response or progressive disease. Now, with all that success story that we had with immunotherapy, what made immunotherapy very, very interesting for the whole field of cancer treatment is because the treatments with chemotherapy, especially in the advanced stage, has always led to patients failing their battle at some point, at any point, when they're getting chemotherapy. So if you have a stage 4 disease, you'll hear more likely that the patient might not be curable. And what I mean by that is that they will go with chemotherapy, they will actually do well for some time, and then their disease will grow, and they'll go into another line of therapy, and then their disease will grow again, and then eventually they will succumb to the disease and die. And this is where basically the survival goes down, down, down. Well, what we achieved with immune therapy, and that has been different from chemotherapy, is that it's true that not everybody responds to immune therapy, but there is a bunch of patients, about 20 to 40% of the patients, that's still alive after many, many years. And this is why we talk about durable responses, and potentially in the future, we can talk more about cure. Now, with that success stories with the checkpoints and immune therapy, that basically led to the field to call immune therapy the new revolution of treatment for the last 2 decades or 3 decades. And the two scientists that were behind that all work, actually, they were granted or scooped a Nobel Prize in 2018. Now, with that, what happened is there was a bubble with that basically advance and that response or that success story. That has been a bubble of immune therapy trials all over the place in all different tumor types, and you basically see that more than 1,000 or more than almost 2,000 clinical trials now testing immune therapy, whether alone or in combination. And the idea is to see if we can make treatments better, especially after failing chemotherapy. And the more and more we see that basically the combination treatments are more effective than just immunotherapy alone. Or sometimes the combination of 2 immunotherapies is more successful than one drug alone. So going back to lung cancer, what we know of is that the lung cancer is probably the second most common or more common in incidence in males and in females, after prostate in males and breast in females. But it is the #1 leading cause of death in the United States among all other cancers. And this is very important because we should not take things lightly with lung cancer. We should go ahead and proceed with treatment as soon as possible. Now, for the most part, unfortunately, the majority of patients, they present with an advanced stage. So for the most part, probably more than 50% of the patients will be coming in to see us, and they already have a distant disease or diagnosis having as stage 4. And the reason for that is because the disease is very aggressive. And it happens that the patient might not notice within a few months the patient might be in actually stage 4 disease. Now, what are the determinants of risk for lung cancer? There are things that you already know. Take the example of tobacco. I get this all the time. Doctor, is it true that if I smoke, I'll get lung cancer? Well, you are at risk of lung cancer. It doesn't mean that you're smoking that you actually will have lung cancer, but more than likely you have a chance of getting lung cancer. But tobacco itself is not just the one risk factor. There are multiple risk factors, and I highlight a few of them here. One is personal history of other cancers or family history of cancer, and also obesity. Obesity is another risk factor for developing lung cancer. It's very important, as well as having inflammation in the lung like COPD because of smoking, and also smoking as a secondary smoker or a passive smoking exposure from a partner or somebody that you live with, for example, or work with. So that being said, there's very significant data around the screening for smokers. And that being said, the studies have shown that if you screen early, you can save basically or reduce the risk from 2% to 1.7%. And that could save basically patients from dying from lung cancer, especially that I told you that the more advanced disease, and I'll show you in data, the worse the prognosis for patient or the higher chance of dying from lung cancer. Now, the guidelines have changed recently, and the key thing here to know is that if you smoked more than 20 years, on an average 1 pack a day, so we call it 20-pack year, and you actually stopped less than 15 years, then you would qualify if you are between 50 and 80 years of age for a low-dose CT scan. If I see a patient in my clinic coming for any other reason and I see that they have this history, I will do a screening for them. Same thing applies for primary care physicians or any physician that you go to. They should be reminding you of this as a very critical thing. And typically it's a screening every year until you become more than 15 years away from smoking or if you're above 80. Again, the key thing is 20-pack year, less than 15 years of quitting. So if you're still smoking, you qualify. If you've stopped more than 15 years, you really do not necessarily qualify. All right, I told you that the survival depends on the stage. You always go to your doctor and say, doctor, what stage I am, or am I? Am I stage 4? Am I stage 3? Because you hear about these things that basically, depending on the stage, your disease might be more fatal. And it's true. Stage 4 is certainly fatal, but I showed you potentially there is a potential of durable responses with immunotherapy. If you look at the curves, again, I don't want to be too technical with you on this, but if you look at the curves, for these different stages 1 through 4, you can see that at 60 months, the people surviving are 82%, but that drops to 6% for stage 4. Now, what we're trying to do is move these numbers up for any particular stage when we're giving immune therapy. And you can see the curves here, how much people are left alive. That basically the 6% compared to the 82%. And it's true, it's not stage 1 and 2 and 3 and 4, but also different stages within each stage. So 1A, 1B, and this is something that your doctor will be advising about and will be looking into discussing with you when he sees you in the clinic. If I break that down to a simpler way, looking at the SEER data, and this is one of the statistics that we rely on, the way I look into lung cancer is, and the SEER data looks at it the same way, is whether it's localized, meaning it's very localized in the lung, meaning in a small part of the lung, versus regional. What that means is going to the lymph nodes, and I'll show you in the next slide what that means. Or distant, meaning going outside the scope of the lung to other organs. The survival at 5 years drops significantly from 63% to 7% in non-small cell lung cancer compared to small cell lung cancer, which is more aggressive. And I'll be talking about the histology in a second. It's more aggressive, so the chances of surviving small cell at 5 years is 27%, and the distant is 3%. And that's probably, still not reflecting the benefit that we got from immune therapy, which might change those numbers as we go with more statistics for the coming years. Now, what are the determinants of therapy? And what I mean by that, you go to see a doctor, you have lung cancer. So what makes it, possible for your doctor to make a decision on your treatment? It really depends on the stage. As I explained, each stage will determine the prognosis, but also it will determine the type of treatment that you get. And basically what I showed you is that if the disease is localized into the lung parenchyma or the lung tissue, that would have a different treatment compared to a disease that is going to the lymph nodes around the windpipe. And the way things are looked at in this cartoon is that lung is seen as an inverted tree. Now, the reason why I say that is because depending on where the disease is infiltrating, that would determine if we can actually cut a piece of the tree or not. And what that means, can the surgery be done or not? If the disease is involving the trunk or the main trunk, You cannot do a surgery because you don't want to cut the whole lung out. And this is the basis of understanding surgical options for you. And I hope that your doctor would be able to explain things when approaching your case. Now, the other determinant is histology, and I told you there is small cell and non-small cell, and I apologize for this as non-small cell rather than not small cell. And this is determined by the histology. You take the tissue to the lab, and it will be determined based on the histology and immunohistochemistry what kind of tumor you have. And the small cell is determined by looking at the under the microscope into seeing basically those small cells that are bluish in color, and the pathologist should be able to make that call for you just by looking at the slide rather than doing anything else. Now, it's not only one histology. It's not just small, non-small. Even non-small has multiple different types, including adenocarcinoma and squamous cell carcinoma that are more common. And this is something that you should know because that would determine what type of chemo or what type of immunotherapy you would benefit from. The more important thing nowadays, and this is something that you should be aware of, is the basis of the basics of biology of tumor. Again, it's not just the histology, but also the what we call molecular determinants of the tumor. And what that means is what gene abnormality each tumor has. And what that means, each tumor is different. Even squamous or adenocarcinoma, each single tumor is different from the other. And this is determined by the genes that are in the tumors themselves. Do they have an error in this gene or that gene or that gene? Now, I put this more up-to-date list from the NCCN guidelines. And this is to show you there are certain biomarkers that we look for early on, especially if you have advanced or metastatic lung cancer. Your doctor needs to send for a genomic test or something called next generation sequencing or NGS testing, whether something you might be familiar with like the Foundation 1 testing or CARES testing, or even if the tissue is not sufficient, your doctor can send for a liquid biopsy like the Garden 360 testing. Now, that being said, what you should know are the big terms of things. So you might be talking to your doctor and he would mention things like EGFR or ALK or ROS. These are all genes that could be mutated. But more importantly, what I mentioned to you about immunotherapy is PD-L1 testing that I showed you the images before on it, is to look whether it's expressed in more than 50% or than 1 to 49% or moderate expression or a negative expression, which is less than 1%. And that all combined whether we have mutations. And this is what is referred to as actionable molecular markers, which are these things, which are EGFR, KRAS, ALK, and ROS, and other. And this is very important when you're actually getting treated for lung cancer. Now, I want to stop here for a second and define for you a few terms that you might hear from your doctor. And it's very important for me as an oncologist that my patients be very well educated about things that we talk about. The first visit with your doctor can be overwhelming. And I take this opportunity here with the association to talk about these so that this could be a reference for you when you're visiting with your doctor to learn about this. So when we are approaching patients with treatments, there are different times or different applications or intentions of the treatment. And what that means, if you have an early disease and you have a disease or a tumor that actually cannot be treated with, let's say, a modality of treatment, and you need something to treat it before you do the surgery or before you do a definitive treatment. And when we say definitive treatment, means a treatment that is intended to cure you. So definitive treatments for early lung cancer include, for example, surgery, and I'll be talking about this in a second, or concurrent chemoradiation, which means chemo and radiation therapy in the same time, or it could be radiation therapy for earlier stages. Now, sometimes, let's say concurrent chemoradiation therapy, we cannot do because there is a lot of tumor and the radiation oncologist cannot give you that dose of radiation because it will hurt you too much. So sometimes your doctor can actually refer to do a treatment before this definitive treatment. And this is what NEO means. NEO means before, or before the definitive treatment. So neoadjuvant means before the definitive treatment. So if you're getting chemotherapy before your surgery, that's called neoadjuvant therapy. Now, what does adjuvant mean? So adjuvant is next to or after. And adjuvant means typically after definitive treatment. And what that means, typically the surgery. So if your tumor is resectable, that means the surgeon can take out the tumor. Then afterwards, for stage 2 to 3, you more than likely will benefit from additional chemotherapy because, and I'll explain why, because we believe in those stages, if we were to leave the patient without treatment, and this is true, this is what the data shows, your disease will come back. And how does it come back? Because we believe that at the time you had the diagnosis of the disease, there are microscopic cells that we cannot see by scans. So although your scans are showing that your disease is only in the lung, it might have sent out some cells of the tumor or seeds that went out to the lung, to the liver, to the bone, etc., that will show up in few years. Now, to prevent this from happening, we do adjuvant therapy, which is typically chemo, or nowadays we can do immunotherapy as well, is to prevent that from having a recurrence. Now, in the earlier stages, I'll show you there is actually up to 40% risk of recurrence, even in the early stage disease. All right, what's the intent of treatment? I told you one is to cure you, meaning to get rid of the cancer and hopefully it doesn't come back at all. And this is what the intent for surgery and adjuvant and neoadjuvant therapy is or are. While palliative therapy is in stage 4 disease, where we know that we cannot cure you, or at least we think that we cannot cure you, we do what we call palliative disease, palliative treatment. And the intent is not to go for cure, because you will be more likely to receive lighter chemo or to be less subject to aggressive chemo, just because the intent of the treatment is to palliate and make sure the disease is under control and make sure you have a good quality of life rather than anything else. Now, the line of therapy is usually applied for metastatic disease. We start usually with the first line of treatment, and this is very important to you for you to understand, because the application of treatment might differ, or the options of treatment might be different. So first line of therapy is the first time you get a treatment for a metastatic disease, for example, while second line is after you fail the first line, where your disease is actually progressing on treatment. I hope that was helpful. Now, moving on with early lung cancer, I told you the initial treatment or treatment of choice is to cut that off, that tumor off, all right? And that's surgery. So the treatment of choice for early disease is surgery. Now, surgery of choice is a lobectomy, meaning a part of or a lobe of the lung will be taken out. Now, can we take a smaller piece of the lung out? Yes, in very specific situations, which I will not get into, but it has to be very small peripheral tumor that potentially can be taken out without going into taking the whole lobe. Now, sometimes, you might need to take the whole lung out, and that could happen. All depends on how aggressive the disease is. Always remember that inverted tree concept, and this is what determines for the surgeon if he wants to do a small a piece of the tumor, small piece of the lung, or the lobe of the lung, or the whole lung. Now, for smaller tumors, especially that we cannot do surgery because, let's say, the patient cannot tolerate surgery, their pulmonary function tests are not good, they might benefit from a definitive treatment with radiation therapy. Now, if somebody we cannot operate on, whether it cannot be resected because of the advanced disease, like 3B, for example, or 3C, or the patient cannot tolerate the surgery itself for different reasons, medical reasons, let's say, then the definitive treatment becomes combined therapy, which is basically a combination between chemo and radiation therapy. And if the patient were to have the combination treatment or have the surgery, they would qualify for adjuvant therapy. And nowadays we will talk about immunotherapy. And this is where I want to walk you through some of the approvals of treatment in early lung disease. So what we have so far is 2 immunotherapy drugs that are FDA approved already. One is called durvalumab, and again, it's a drug that targets that PD-1, PD-L1 axis, so it blocks that checkpoint from inhibiting the immune cells from working. And typically, we give it for about a year, and this is based on the Pacific trial, We do not need a biomarker for that. So once you actually respond well after concurrent chemoradiation, meaning you've had an advanced disease, locally advanced disease, your doctor gave you chemo and radiation therapy, and you responded well after that, then you qualify regardless of what biomarker status is. You don't need to be tested for that, for getting durvalumab for a year. And typically we give it as every 2-week cycle, meaning one infusion every 2 weeks. And the benefit of this, here I will define what the hazard ratio, it's HR, I refer to that as the hazard ratio. It's basically, you can see it basically that the hazard ratio is 0.68, or basically it's about 32% reduction in the mortality. So we benefit by reducing the mortality rate by 32%. So what that means is actually that you're getting a benefit of, or chance of, almost more than 30% of being alive at 1 year or even later. And this is very important. Now, the other approval we had from the FDA based on the IMpower 10 study is for those that had resectable disease, that you actually, after you have the resection of the tumor, usually we used to give only chemotherapy as adjuvant therapy. Now, we know that you can actually add, after the chemotherapy, immune therapy with atezolizumab, another checkpoint inhibitor, that would actually give us also about 34% chance of better survival. And for this one, to qualify for this one, you need a biomarker to be tested for, and that's be the PD-L1 testing that I showed you, and it's the TC score, which I educated you on initially, and it has to be done as under FDA companion diagnostic, which is basically testing with a Ventana test for the clone of the PD-L1, because these different PD-L1s come in different clones or different flavors, and it's called the SP263. And your doctor should be educated about this to do it for you without having you knowing about this. All right, so I told you that after treatment, we have an advancement of improving survival early in the lung disease. So what about the moving the treatment even earlier in treatment, or actually improving on that adjuvant therapy? So things have been evolving over time. Now they have studies that have been looked into that, and one of them is, can we improve on that 32% to make it actually higher, meaning more benefit of survival for patients? And this is where actually a continuation of the Pacific trial kind of concept, but basically to add to durvalumab that was approved, other drugs that target the immune system. If you remember, I told you that there are actually other cells that can suppress the immune cells from working. This is where new drugs that target the immune microenvironment, called oleclumab or monalizumab, that target, for example, the NK cells and the IDO pathway, to improve on the outcomes. And this has been presented at the European Society of Medical Oncology just recently, and shared by the company to show that the combination treatments after actually the patient have received their initial therapy with concurrent chemoradiation therapy, to add durvalumab and the other drugs, that the combination between the drugs have been more effective than the durvalumab alone. And you can see this in the curves here. But to summarize it, the hazard ratio for the combination of durvalumab and oleclumab has been much more important than the other two. And you can tell by basically the hazard ratio being 0.44. We're talking about 56% reduction, which is humongous. And this is something we look forward to in potentially approval for this kind of disease, hoping in the near future. All right, we have been looking into after surgery or after concurrent chemoradiation. The field of immunotherapy is looking to see if we can even move the treatments even earlier in the disease, meaning before even we do any surgery. And this is what this study is looking at. This is the Checkmate 816. And this is looking to see if we actually give combination of chemo and immunotherapy early in the disease in patients that have a disease that can be resected, do we get a better outcome? Now, with this treatment, the potential of the importance of the response in this case is actually, and I should take this back. This was an error here. I apologize for that. This hazard ratio is for the prior study and not for this one. The biomarker in use here is PD-L1, but what we know from this study that patients who have had the treatment early on with nivolumab, another anti-PD-1, PD-L1 drug, is basically that they had significant reduction in their tumor when we looked at the microscope after surgery. And this is basically shown here, basically depending on the stage of disease, and you can tell basically significant increase in the pathologic complete response. And what that means is basically how much the pathologist was able to show that the disease is being dead. So the more the number, the better outcome is. And you can see that across the board for all stages, we had actually better outcomes compared to the standard treatments. So this is probably coming up, and hopefully we will see more results as we go. Now, I say here, stay tuned for the NeoCOAST, the same trial that I showed you that uses durvalumab and oleclumab or monalizumab is coming up in the neoadjuvant setting. Now, for the most part, I think the studies are moving to do early on in before the surgery and continuation of the treatment after the surgery. And here I have a couple of clinical trials if somebody is interested to look at, but really those are still in the early stage of development, and we don't have much of outcomes that we know of. But these are different treatments options that will be coming, or clinical trials that you as a patient with lung cancer in the early stage of lung cancer, you could potentially participate in. And I'll leave it out there without talking about too much details because we are not at a stage where we can talk about results yet. Now, for advanced stage non-small cell lung cancer, I told you that it all depends on the biomarker and the histology, etc. And this is a very complex slide. I don't mean to go over it completely with you. All I need is to show you that basically the treatment all depends on those different determinants of treatment. And there are multiple options for you. But what I want to focus on is the advancement in immunotherapy in advanced lung cancer. And as you can see from this cartoon, if you look, it depends on those biomarkers. Now, the first thing your doctor would want to do is the testing for biomarkers that are EGFR, L-CROSS, and others, because if you have that, basically you would qualify for a targeted therapy, not immune therapy. And then, if you don't have that, your doctor will look into your PD-L1 testing that we talked about and determine what would be the best treatment for you. And he will be looking at the histology, because depending on the histology, whether it's squamous or non-squamous, that will make a difference. What you should know from this slide is that immune therapy, whether it's pembrolizumab or actually nivolumab or atezolizumab or other, has been approved in every single first line of treatment. Every single line of treatment for lung cancer has been approved. Now, the first line I told you that I defined before would include chemotherapy with immunotherapy, regardless of the PD-L1 testing. But it will be important that if you have, the PD-L1 score will be helpful to determine whether you benefit from immunotherapy alone or the combination, or actually immunotherapy plus immunotherapy. And in this case, it's ipilimumab and nivolumab. And the second line therapy, depends on the first line and the biology of the disease, as we explained. So far, the future is bright. I think we have now immune therapy agents in every single lung cancer. Now, I haven't mentioned small cell lung cancer, but actually it applies also to small cell. Now, the first line therapy for small cell lung cancer would actually include chemo as usual plus immune therapy. And you can have more information on that if you want from me. We can talk about this in chat or in questions or maybe offline. The other forms of immunotherapy. So I was focused all the time talking to you about T-cell checkpoint modulation. Now, there are other forms of therapy that are out there. One is engineering the T cells that we talked about in order to make them actually detect those tumors by finding something that the tumor only itself expresses compared to the normal tissue. And this is what happens if we take some of your T cells out, or not necessarily just T cells, but we can do other forms of cells like natural killer cells or others and make them actually be activated against a marker in the tumor, and we send it back to the infuse it back to your body, and that will go and try to kill the tumor. So it's actually activated outside the body in the lab. And this is what CAR T cells, if you hear about CAR T cells, are the way they work. Now, there are other antibodies that are part of the immune therapy, and we're not going to go into this today. But also there's some talks about therapeutic cancer vaccines, not just vaccines to prevent cancer like the HPV vaccine or the HPV vaccine, but are there certain vaccines that we could use to actually help get rid of the lung cancer? There has been trials of different cancer vaccines on lung cancer, whether targeting, for example, MUC1 or the MAGE or other proteins in the tumor. But really, the success stories behind those have not made it to a point where we got any FDA approvals. Now, you might see in the news, potentially, there is a trial in Roswell Park that actually using a vaccine that came from Cuba, and it's approved in different countries. It's called Simavax, and they're using it now in combination with immune therapy. We stay tuned for that. We don't have any major outcomes yet that I would recommend to go ahead and try it, unless you're actually going on a clinical trial. But I think the future is bright in terms of further development of cancer vaccines that will actually help get rid of the cancer. All right, I'll pause here a little bit to talk about, what are the potential side effects of immunotherapy, because that's a very important topic, especially that if you're doing it now, or you're actually being treated with it now, or you're going to be considered for it. And I'm going to tell you sort of basically what I tell my patients in the clinic, so that basically it becomes sort of assimilated or easy to digest. So first of all, what you need to remember, that immune therapy is meant to work on the immune cells. That's what we know so far. At least that means that we are trying to enhance the immune cells to be activated against tumor. Now, unfortunately, when we do that, what we find is that the immune cells, when they're activated, they're actually activated also against anything, especially parts of our body, which means our normal tissue. And that could include any part of our body, any tissue, any organ in our body. That means the immune cells have the capacity now, potentially, and again, it's not that frequent, we're talking that everyone have those side effects, but there's a potential that patients might have side effects in any of the organs. And we start with the common ones. The more common ones are basically affecting the skin, and you might have some sort of inflammation on the skin or a rash. And the other common one is the endocrinopathies. And what that means is basically that the disease is affecting actually your endocrine organs, if I highlight that here. And what that means, the endocrine organs or the glands. So we're talking about the thyroid gland, we're talking about the adrenal gland, or even a part of the gland in the brain. So the inflammation of those organs might lead to what we call endocrinopathy, or loss of function of the gland. So the typical example is hypothyroidism, which means low thyroid function, and the typical treatment for that is replacing the hormone. So if you have hypothyroidism, God forbid, you will need to go on a hormone replacement with levothyroxine or Synthroid, or basically the thyroid hormone. Now, this is all tolerable, but the other things that could happen is fatigue, and maybe GI upset, etc., which are non-specific to immune therapy. But the more serious things are the things that could affect the noble organs. We're talking about the heart, we're talking about the lungs, we're talking about the kidneys, we're talking about the liver. And some of those actually might show up as symptoms. And I always educate my patients that if you're coming to see me in the clinic, the reason why I see you is for safety check. And what that means, check in on you to see if you have any symptoms, but also to look into the lab studies to see if you're developing any of the side effects that could be early on and you don't feel anything. So for example, the kidney dysfunction could not show as symptoms, but it will show with the increase in the creatinine or the glomerular filtration rate. Same thing for the liver. Liver enzymes might go up without the patient feeling anything. And same thing for the heart. Also, we might have that, but for the most part, the more serious things could also show up as symptoms. So I give the example of colitis, which is inflammation in the colon. For the most part, patients might have diarrhea, or they might have a real colitis, which is inflammation that causes basically belly pain or abdominal pain and the mucus in the stools and potentially bleeding because the irritation of the lining of the colon has been severe enough to cause basically loss of the barrier and potentially erosion into the blood vessels. Now, for that reason, it's very important that you report any symptoms you could have to your doctor so that they actually can address that immediately. Now, other symptoms that could evolve also including the nerves. So some patients have had Bell's palsy or neuropathy that could also evolve. Now, what's important is that when you're being considered for immune therapy, that your doctor looks into your past medical history and see if you have any predisposing condition, especially if somebody has inflammatory bowel disease, for example, Crohn's disease or colitis. That might be a no-no to go on with the treatment because it might exacerbate your inflammation that you have to start with, and that might make your life at risk. Now, we talked about the hormone replacement therapy as potential treatment, but we can use antidiarrheal medications or anti-itch because itching could happen. But also, when the inflammation is bad enough, we might have to look for more serious guns, and we're talking about the steroids like prednisone. But sometimes prednisone or dexamethasone, those steroids or corticosteroids might not do the kick, so we need bigger guns. And this is where we go for more immune suppressants like interleukin 6 inhibitor or other drugs. That being said, it's very important that you always be up to date with your symptoms with your doctor. Moving into another topic, because I was asked to talk about COVID, while we're talking about lung cancer. So what you should know is cancer by itself, regardless of the cancer, it is a major risk factor for COVID infection. And what that means, COVID infection could, evolve as you probably are familiar with this, but something to remind you that for the most part, the symptoms include flu-like symptoms, cough, shortness of breath, even diarrhea, or basically loss of taste or smell. And these can be also part of the side effects from the treatment. So very important to kind of keep that in mind. Now, typically your doctor will send a testing for that, whether it's RT-PCR or antigen testing or other, and you could be infected and be treated inpatient or outpatient. And there are different risk factors for, the different risk factors that determine whether the patient might get this kind of treatment or that treatment for COVID infection. Now, the complications of COVID can include the lung, kidneys, liver, brain, nerves, heart, and blood. So again, putting that into the perspective when you're getting immunotherapy, just be reminded that this could be could cause issues. Okay, what about COVID-19 treatment? I think there are multiple treatments that you have heard of, but there are different options out there depending on the severity of the disease and whether you have low oxygen levels or whatever risk factors for it or not. But those include antivirals like remdesivir or steroids that we use for side effects from the immunotherapy. One important thing to mention here is that steroids have typically been avoided at high doses in immune therapy because it might negate the effect of the immune therapy itself. There are other treatments that are out there for COVID-19 infection. You could consult with your doctor whenever needed, but I think also you should be reminded that you might be at risk of blood clots, and this is where anticoagulation or blood thinners might be needed for COVID-19 treatment. How do we prevent this is very important, and there will be a sequence of questions that come after that. And we do vaccines, and there are different vaccines available there, whether it's the messenger RNA vaccine, and we're talking about the the Pfizer and the Moderna, and they're more than 95 or more than 94% effective. And there are other, types of vaccines like the replication and competent adenovirus. I'm talking about Johnson & Johnson and AstraZeneca's. And also they have efficacy of about 70%. Now, the common side effects is the infusion site reaction and the flu-like symptoms. These are the common things that could happen. And what that means, you'll be sore at the time, after the injection, or you might have redness around the site of the injection. But they're rare side effects that could happen. And one cannot deny it, but one should not overwhelm themselves with those because it's very, very rare. So the benefit outweighs completely the risk of having the COVID vaccine. Those include basically anaphylaxis, meaning your blood pressure might go down and you have basically a severe inflammation, a severe um, reaction to it, or heart inflammation, or some neurologic side effects like Guillain-Barré syndrome, or thromboembolism, or clots, or drop in the platelet count. Now, for the most part, this is very rare, and the treatment options for that are well known so far. All right, I'm gonna put some facts and myth about the COVID vaccination. Um, I should say that most people with cancer have a weakened immune system. That's true. Cancer patients may still develop immunity against COVID-19, yes, and there actually has been a study recently to show that non-small cell lung cancer, meaning lung cancer patients, actually they mount a good immune response to COVID-19. And I was just at the Society of Immunotherapy for Cancer. We showed actually we had data to show that even patients that do not develop uh, uh, antibodies against COVID-19 with the vaccination from the first dose and second dose, they can actually catch up with the booster. So it's very important for a cancer patient to do the first, second, and the booster or the third dose. All current COVID vaccines are effective, that's true. And the pandemic caused delays in care, of course, especially when surgery. So if you're a lung cancer patient that needs surgery, sometimes, especially during the pandemic, your surgery might have been delayed because of different reasons, to include basically testing you for COVID. Did COVID affect your doctors, how they treat you? Of course. And that has to do with basically being lighter on you rather than going, more strong on the chemotherapy treatment. The myth that you should be aware of is the COVID-19 vaccine causes variants. That's not true. It contains microchips that the government is using for, spying on us. That's not true. COVID-19 vaccine causes you to be magnetic. That is not true at all. COVID-19 vaccines alters your DNA. That's not true. And COVID vaccines are not safe. That's not true. For the most part, they're safe. Are they coming with potential side effects? Of course. What about the COVID vaccine lung cancer? Do I need to get my shot? I said yes, then yes, we need to do it. Do I need a shot if I got infected before? We just had data to support that. Yes, you actually will benefit if you had the infection before. It's supported by data and not just fantasy or expert opinion kind of thing. Does a shot delay my scans? Yes, it could do that. Do my treatment affect when I get a shot? Yes, and I'll explain why. Do I qualify for a booster shot? Yes, you do. If you have lung cancer alone and even no other comorbidities, and you qualify for the booster. The reason why that might delay your scans, and very important, is that when you get the COVID vaccine shot or any shot, that actually the way it will make the immune system work is by developing immunity in the lymph nodes. And those are the summer lumps that could develop under the armpit. So if you have a cancer and we're looking to see if you have any disease anywhere and you got the vaccine and you have a lymph node that actually evolved under the armpit, I, as a doctor, looking into the scans, I could not tell whether this is actually the tumor or the immune system reaction to the COVID vaccine based on the scans. And this is very important to be discussed with the doctor, especially to make sure that the COVID vaccine is away 4 weeks from the any imaging. I finished with this. This is basically resources for you by the Lung Cancer Association, American Lung Association, I'm sorry. And you will get this by email, as well as the other resources from the American Lung Association, talking about immunotherapy, mentorship, and other resources. And with this, I thank you for attending this talk, and hopefully I can answer any questions you have.
Great. Thank you so much, Dr. Sater. We do have several great questions in the chat. So I'm going to go ahead and read those to you. I'll do one at a time and have you answer those. This is Dr. Sater. Thank you for the presentation. Are there some cases where you had a different diagnosis of lung cancer, 2 different types based on histology? And in that case, which treatment strategy is best for your patient?
That's an excellent question, actually. We do have some gray zone. That's right. So based on pathology, there are certain times where we have gray zone between like squamous and adeno, and they might be adenosquamous. That would affect what I do to avoid basically anything that could raise the risk for the patient. So we know, for example, for squamous cell carcinoma, some treatments could cause actually bleeding for the patient, so we avoid those. So if that is the case, I would avoid those regimens that could actually put the patient at higher risk.
Okay, great. And also from the same viewer, if a patient is responding and tumor size is reducing based on CT scan, will you consider radiotherapy, and how long would you keep the patient on immuno and chemo?
That's an excellent question. So again, it depends on the stage, but yes, there are instances where actually, as I mentioned in the talk, that we start with actually chemo, we reduce the size of the tumor, and then we go for radiation and chemotherapy, and then we put the patient typically on immunotherapy. If it was durvalumab, for example, it's going to be a year of treatment. Now, all dependent on the patient's response and the patient's tolerance of the treatment. Sure enough, if the patient cannot tolerate the treatment, we'd have to stop.
Great, thank you. The next question is, what's the criteria you follow to go ahead with radiotherapy? That's aside from patients' comorbidities.
So that's a great question too. I think, you know, the comorbidities, the size of the size and the location of the tumor, the stage, of course, will be determining that, but also the pulmonary function tests. And that's more the expertise of the radiation oncologist that will advise us whether, you know, they think that this is something that the patient would tolerate or not. And that has to do with the residual of the lung function. In other words, if you take the lung and divide it into different compartments, each compartment will give, let's say, an amount of oxygenation to your body. If you were to do a radiation and that radiation might affect, let's say, 30% of that, you might still be okay with, you know, still functioning afterwards without needing to go on oxygen, or your lung function gets deteriorated. So those are the measures that the surgeon and the radiation oncologist use to kind of determine the type of treatment or extent of treatment.
Great, thank you. Our next question is, if a patient doesn't tolerate one immuno agent, would they be most likely to not tolerate another?
Really depends on what tolerance or what side effect that is. I do think that, you know, for the most part, if, you know, the patient does not tolerate and we had to stop the immunotherapy, for the most part, we give a break for some time and then we challenge the patient, even with the same drug. And actually, there was a study from, you know, Dana-Farber that actually looked at that, and about 40% will have some sort of recurrence of the side effect, but again, 60% did not.
Great, thank you. Our next question is, if is immunotherapy possible in patients who are immunosuppressed, such as a solid organ transplant recipient?
Unfortunately, they would not, based on what we know so far, because that would put them at higher risk of rejection, which would mean taking their life away. So I'm not aware of anybody that's tried that, and I don't think it makes sense to try that.
Great, thank you. Our next question, would high-dose steroids to treat a side effect of immunology counteract any benefits of the immunological treatment received prior to the onset of their side effects?
Amazing. Actually, I'm getting a lot of excellent questions. And I appreciate the audience for that. That's true. So they're actually questionable, you know, alteration of the course of, you know, response to immune therapy if you were to use high dose steroids. But all depends on how long are you using the steroids for. For the most part, if you have like grade 3 or grade 4, you know, side effect, and we needed to use high dose steroids, typically, you know, we'll use it for a short period of time, and then we de-escalate or titrate down. And what that means is we give it for a short period of time, and that should not necessarily affect the long course or the natural history of the disease. But it is true, if you were to put a patient on high dose, meaning above 20 milligram of prednisone or more than 10 milligram of prednisone, you might be risking the benefit of immune therapy.
Great, thank you. Our next question is, what are your views on the duration of immunotherapy treatment following a successful response in a stage 4 patient? Should treatment be 2 years? Are there any circumstances under which this might not be recommended course of action?
That's another excellent question. To be honest with you, it really depends on the patient and the course of treatment. For the most part, we say about 2 years of treatment, but there are questions out there whether shorter period of treatment is still beneficial or not. In my humble experience, I think that shorter periods of time might be still beneficial. I'm not recommending this as a practice, unless we have clinical trials that would actually provide that evidence. But in my opinion, especially if the patient were to develop any side effects, I would be more inclined to hold off on the treatment and always be able to go back on treatment when the patient, God forbid, has a recurrence of disease. Have we done this, in practice and on clinical trials? Yes. But again, this is not like a full-blown recommendation or like a recommendation that is evidence-based.
Great, thank you. Our next question, is it advisable to consider immune therapy in parallel to effective TKI?
That's an excellent question. Actually, the addition of TKIs to immune therapy has proven to be very, very effective in multiple cancers. I give the example of renal cell carcinoma, for example, where the TKI, particularly we're talking about VEGF inhibitors or vascular endothelial growth factor inhibitor, has been very effective in actually adding on to the effect of immune therapy. And that has to do with the work on the microenvironment that is immunosuppressive, as I said, and those T regulatory cells and the VEGF and the TGF-beta pathway.
Great, thank you. I have 3 more questions, but I did want to make a reminder to the audience that everyone is in mute only. So in order to ask your question, please put your questions in the chat screen on the right-hand side. I saw we have a few hands raised, but we're not able to unmute individuals. So please put your questions in the chat. Okay, so our next question is, why stop immunotherapy after 1 year?
All this has to come down to weighing risks and benefits. And for adjuvant therapy, I think the question is about durvalumab, why stop after 1 year? I think, when I'm, let's say, designing a clinical trial, I'm always thinking of the risks and benefits. And I think the way the design of the Pacific has had that in mind, meaning that is 1 year enough? And I think that was an excellent point, rather than like continuing forever. There's no point in continuing forever, especially if the patient has, had a good response. And the reasoning behind it, or the rationale behind it, is that really what we're trying to build with immune therapy is that memory. We're trying to build a memory against the cancer, making sure that your immune system recognizes the cancer as a foreigner and stopping it away from coming back. Whenever it comes back, if there is a cell out there that is a seed in the liver or the bone or other, and it's starting to make itself as a clone and make a cancer again, the immune system will come and recognize it and will get rid of it. So if we build a memory, then there is no point in giving it forever, if it makes sense. Plus, the more you have it on board, the more you have a chance of having side effects, which are the immune-related adverse events or immune-related side effects.
Thank you. We have 2 more questions. Is a history of multiple sclerosis an absolute contradiction for immunotherapy?
Yes, I think so.
Okay. For stage 4 non-small cell lung cancer, if a lab result returns with no significant biomarkers, e.g. PD-L1 at 1%, any immune options?
Of course, that's an excellent question, actually, and that is a good point, because I think I have not addressed it specifically, but I think, yes, the point is, if you do not have any of the target or molecular targets that we're talking about, EGFR, L-cross, and other, and you do have, you do have the opportunity, of course, you have the opportunity to get immunotherapy in combination with chemo or combination in other immunotherapy. So yes, you do qualify if you have no actionable mutation. So the idea behind that is to look if you have any actionable mutation to use that drug that target that mutation or that molecular target before you do anything else, because the response to the targeted agent or target is very, very effective. All right. So although immunotherapy has been excellent, should say that those molecular targets are very important, because if you treat with the drug that actually against that target, you will get great results.
Great, thank you. Can a doctor use a treatment that has not been approved by the FDA yet?
That's a good question. Can a doctor do that? He's not supposed to do that. Do people do that? Yes, there's actually something called off-label use. Well, actually, I should take that back a little bit. If the drug is approved by the FDA for another indication, then doctors in the US can actually make use of it for another indication as an off-label use. Is that something recommended? No. Do I do it? No. But yes, that's a good question, and I don't know if this has been done or not somewhere, but I mean, I'm sure the people do it.
Great, thank you. And our final question is, I finished a year of Imfinzi. How long does it still stay active in my system? Very nervous, going on 3 months now with no treatment before next CT scan. I'm a stage 3B non-small cell adenocarcinoma.
Yes, so this is what we're talking about, stage 3B non-resectable disease. The patient likely had concurrent chemoradiation therapy, and she did well with the treatment, and then she went on Imfinzi or durvalumab for a year, and she stopped, and she's now concerned whether the disease will come back or not. I should say, rest assured, more than likely you will not have the disease back, especially if everything has been in check before. Now, is there a chance that this can come back? Yes, of course, but again, I am a positive person. I always stay positive. I always tell my patients stay positive, and the risk is much less, to come back, because typically all treatments used to be, only chemo, and yet the patients would have up to 40%, chance of having a recurrence, right? Now with the Imfinzi, the chance is much less, really much less, and I hope that none of the disease will come back. And please do not be anxious, because I feel like that your disease has been under control. I hope so, and just wait for the scan, and I'm more than positive that it will be negative.
Great. Dr. Sater, thank you so very much. This has been a wonderful program. As you can see from the great attendance and the very insightful questions from the group, we do appreciate your commitment and time to helping us launch our lung cancer patient virtual meetup on the Go series. This program is being recorded, and we will have it available on demand, and everyone will receive the information for the on-demand videos. And again, thank you, Dr. Sater. We appreciate all the great comments.
Thank you, and thank you for the audience. They were excellent.
Thank you. Have a great day, everyone.